Welcome. All right, welcome. Hello, my name is Lindsay McDermott, and on behalf of the Office of Oral Health, we would like to welcome everyone to our February 7th virtual project directors meeting. We'll be talking about the Kindergarten Oral Health Assessment, COA, best practices to maximize success. And today's objective is for local oral health programs to learn how to build or strengthen relationships with community-based organizations and learn tips to improve COA awareness, best practices for data collection during COA, and answers to the top 3 most frequently asked questions for the System for California Oral Health Reporting, also known as SCORE. As we get started, we wanted to thank you for your responses to the registration question about your biggest COA challenge. The top challenge was getting forms returned from parents, which got 30 votes. And there were plenty of other responses, though, on the survey. And so a frequent challenge in the other category was school capacity to upload COA data into SCORE. So we hope that you will find today's meeting helpful for addressing these challenges. And we welcome your active involvement in the discussion today. So this is a 2-part project directors meeting, and we will convene again next Wednesday, February 14th, Valentine's Day, to look at school dental programs, integrating care coordinators and community health workers. We encourage you to ask questions in the chat or use the raise hand feature. And for any questions we're not able to get to today, we want to be sure to follow up. Please, we encourage your participation and want you to feel like your questions and challenges are heard and that we can follow up on those. And it's great to be with everyone today. We last met in November for the Improving Racial Equity Project Directors meeting that was presented by CPEN. So I would like to welcome each of you as local oral health program leaders. We invite you to include your organization in your Zoom name, and we would also like to welcome you in the chat. So we invite you to please include your name and program or county in the chat. This helps our new Office of Oral Health staff know who is who, and it helps everyone get connected. So we also encourage dialogue in the chat for questions you may have for other LOHPs. The agendas and speaker bios were emailed to registrants. Speaker slides and the meeting recording will be made available after the session on the COTAC website, and we'll send out an evaluation following the meeting. So we're ready to jump in, and so I'd like to start and welcome our State Dental Director, Dr. Jay Kumar, to give the opening remarks and introduction. Welcome. And you're on mute.
Thank you, Lindsay. Good morning, everyone. I want to add my welcome to this Project Directors meeting. I want to give update on 2 topics. The first one is on budget, and the second one is on data. So as you have seen, the governor's budget proposal is published now. You can go online, access it, and look at our account. We have expenditure authority to spend about $35 million in the next fiscal year. In May, a revised budget will be presented. The final budget is passed in June, so that's the budget process in California. Based on the current projection, we sent an email to all local health programs with the good news that Office of Oral Health is happy to announce there will be no decrease in your fiscal year 24-25 budget. And on top of that, it appears that we can allow local oral health programs to carry over unexpended funding from year 2 to year 3, unless there are significant changes in the governor's May revised budget. Please look for additional updates about the budget template, as well as other improvements we are making here to better support your work. So if you have questions, please reach out to your grant manager or Kimberly Steele. Regarding the budget, we should get about $30 million annually based on the Prop 56 Tobacco Revenue Tax Act. And if there is a decline, the law provides for backfill through general fund. So we should be all set. There will be some uncertainties about carry forward money and how much more we can spend in a current year. Otherwise, we should be all set. So the next topic is about data. So as your county starts planning community health needs assessment, community health improvement plans, they're going to be asking for data. And as you start looking at your community needs, so you need data. So we have some ideas. And we may have discussed this with you before. First is the kindergarten oral health data. So this is one of the reasons why we want you to collect kindergarten oral health data, because it gives you caries prevalence and untreated disease. These are the two very good indicators about children's oral health. And if you look at San Francisco and how they have used the kindergarten oral health data, that gives you very good idea, and because you can generate zip level data. So some counties have very low participation, say, 5 schools, 6 schools participating. Still, you can use that data. There's this concept of Sentinel survey. You can look at trends over time in those schools. And if you have high income, low income schools, you can look at disparities. So that is what we encourage you to look at local data. And the second is, we are planning our California Smile Survey 24-25, and that's going to be in school years 24 and 25. So you'll be hearing more about this California Smile Survey. This is the survey of third grade children. We have selected 180 schools, about 13,000 children, to cover all counties, but it's not going to be county specific. It will be regional estimates. That's in California, except Los Angeles. Los Angeles will conduct their own survey of third grade children. The procedure is very similar. We can combine it. And we have contracted with UCLA, Professor Hongyu Liu, to develop a method for what we call small area estimates. So we should be able to get some estimates for every county and track progress over time. So we have sent you another data, that's the maternal infant health assessment survey data. We send it every year. Similarly, data on emergency department visits. And you have Medicaid or the Medi-Cal dental data available over the, using the open data portal. So that should be available to you. There is another source of data for adults' oral health, and that's called the Places. It's on the CDC website. For counties, they generate data using the behavioral risk factor surveillance system. For example, tooth loss. That data you may be able to access through Places. If you have difficulty, you can reach out to our team. And there is another source of data called the county health rankings. That is through Robert Wood Johnson Foundation. And you can look at dentists by county in that database. Fluoridation data is available through CDC's My Water Fluoride. And also another source of data is fluoride varnish application in primary settings. And by health plans, by county, that is published every year, sometime in February, March by DHCS. And you can look at that report and see fluoride varnish application in primary care settings. And by now, you should have a very good idea about your school dental programs, all the providers in your county, where they are. And especially in low-income schools, you should have an idea about the number of school-based program, type of programs, And this was one of the activities for you in your work plan to develop a listing of all these dental programs in your county. So that's the update I have about budget and data. And I'm looking forward to this session and the next session. With that, I'm going to hand over back to Lindsay.
Thank you so much. And we have a question in the chat about if the data sources can be shared via email and that people weren't able to write fast enough.
Oh, definitely, yes.
Okay, great. Thank you.
Mm-hmm.
And then we have another question. Do LOHPs who are not part of the SMILE survey have access to the survey so we can utilize the questions in our assessment surveys?
So the method, yes, definitely. The method will be available. I think this is one of the topics for the next PDM meeting, right? Next week, Lindsay, is it? Some more information about the California.
Yeah, yes, about the SMILE survey. There's another question. We'll have some time at the end to discuss the SMILE survey. So the other question, so we can take the questions in now. But another question is, should we wait for the new California SMILE survey to be conducted to start the needs assessment?
No, as I said, you can use the 2018-19 data, if you know, regional data, and also the kindergarten oral health assessment data. So you don't have to wait for the 24-25 survey data.
Okay, thank you. And Ariel, did we get your question answered?
I had another question about the budget, if I could. Yeah, thank you, Dr. Kumar, for that update. And I'm looking forward to the follow-up and email, especially with all those data sources. You had mentioned that we are approved for carryover between year 2 and year 3. I just wanted to put a plug how critical that carryover really is from year to year in order to fund our staff due to COLAs and increases in staffing costs in order to maintain our staff. That rollover is incredibly critical from year to year in order to keep the staff. So I'm not sure if that's something that has to be accounted for or is it not necessarily possible every single year. So I just want to mention that just as kind of a local perspective. Again, I'm just speaking for us in Sonoma County. I see some nods in the virtual room, so I don't think I'm alone in that feeling, but I certainly don't want to just speak. I'm seeing same from Marin. So just wanted to put that out there as something that's incredibly critical for us to maintain our work.
The way it works is if we get the money, we will give it to you.
Thank you.
And it sounds like the flexibility for carryover was part of that. So thank you for lifting that up. Seeing a lot of themes in the chat. And there was one other question. Will we have access to the actual survey so we can conduct the same 3rd grade assessment?
Yes, we will be happy to give you the protocol for conducting the survey if you're interested. But again, I'm going to focus on kindergarten oral health data. So you should work on getting the kindergarten oral health data. There is no need to do a separate 3rd grade survey. The only additional information you get from the 3rd grade survey is CLANs. And you can pretty much, estimate, and that's what we are working with UCLA. There are methods that we can use to develop small area estimates, and hopefully we will have some data for you on caries prevalence for every county.
Great. Thank you so much. Really helpful questions. So we'll move on now to the COA piece, speaking of COA and the importance of COA data. And I wanted to show the agenda on the screen as we introduce our first speaker, because our goal for today is to start with a big picture overview of how to collaborate with partners to promote children's oral health. Our first speaker will be looking at collaboration with managed care plans in particular, and that includes opportunities for collaboration around COA. And then we'll dial into like more and more specifics around COA, including building relationships, how to do the tips for the data collection form, questions that are coming up at SCORE around data, and then we'll have a Q&A that can cover all of those topics. I did want to note that our first speaker will be here up until the break, so we'll do her Q&A right after she speaks, and then we'll do the second half of Q&A after our other presenters speak. So with that, I would like to introduce Fatima Clark. She's the Director for Health and the Children's Movement Equity Fellowship with Children Now, and she'll give an overarching view of collaboration with managed care plans. Welcome. Thank you.
Thank you, Lindsay, and everyone. And I'm familiar with some folks on the call. And thank you for this opportunity to share sort of some of the opportunities that we're seeing to elevate oral health with some innovations that are happening with Medi-Cal managed care plans. So next slide. For folks who may not be aware of Children Now and who we are, we're a statewide policy advocacy and research organization. We focus on all kinds of issues related to kids from prenatal to age 26. We also lead the Children's Movement of California, which is a network of over 5,000 organizations from various sectors who are all united behind a push to ensure that children and youth are prioritized in our state. And so this is we call it a pro-kid network, because these folks come together at critical points in times to push for policies, budgets that reflect the priorities of children and youth and the families in which they live and reside. Next slide. We're a data-driven organization, so I have to highlight two of the tools that we use to show the data that best illustrates some of the work that we advocate for. We just released our 2024 California Children's Report Card. I highly recommend that you check that out. We grade the state on its progress towards achieving equity and accountability for kids, from health, education, child welfare, reproductive justice, oral health, obviously. So take a look. Within it, we highlight the latest data that tells us the current state of kids and youth within each issue area, but we also then highlight the progress the state has made and what opportunities remain to promote equitable outcomes for kids. The second, and these two publications alternate. So next year, you'll see the 2025 county scorecard, but if you wanted to look, we also have the county scorecard, which just has tons of data related to children's well-being. So again, it's not just oral health or health, it's child welfare data, it's education data, early childhood data. So encourage you to take a look, whether that's on your own time, aligned with, on your own time, just out of interest as an engaged community person in your community, or if it's helpful to you in your sort of professional pursuits as well. Next slide. Okay, but I'm here today to talk really about Medi-Cal. And I'm curious, we wanted to get a sense of folks' relationship with their local managed care plans. Now, new contracts went into effect in January, so it may be that you still don't have a relationship with the new managed care plan that's now operating in your county. But we wanted to get a sense as we talk about how to engage managed care plans in ensuring COA compliance or just ensuring access to care for children. We wanted to see where folks are in their relationship building with plans. So do you have an established partnership? Are you exploring partnership? Have you not started yet? And that's totally okay. This is a new requirement on plans. And so some of you may already be in partnership, but some of you this may be the first time you start to sort of think about how you might partner with your managed care plan. I will leave it to the SAC State or Office of Oral Health team to decide when to close the poll. It looks like 40% of folks have participated, so we'll give it a bit more, and I'll let the team share the results. Okay, I think they're sharing the results. I hope folks can see the results. I'll read them out. So established partnerships, about 25% of you have established partnerships, which is great. 50% are exploring, which is wonderful. My heart is like growing like the Grinch's heart, because there is so much opportunity to work with managed care plans, and I do think there are ways that they can support and strengthen your efforts, whether that's the resourcing or data sharing. And it looks like 25% have no collaboration yet, which I hope you will. I hope that this presentation will inspire you to talk with your leadership at your organization or engage managed care plans in your efforts if they aren't already engaged, or if their engagement has been not as robust as you'd like. This might be a new opportunity to revisit their engagement. Okay, I think someone can, oh, I think now we're going to share the results. I don't know, the back end person sharing this. Do we close it?
Yeah, you're good to continue.
Okay. Okay, so next slide. So before we jump into Medi-Cal managed care, I wanted to share the latest, well, some of the latest data that I was able to find that had a nice geographic representation for folks on this call. So based on 2020 data, you can see that Medi-Cal enrollment varies by county. Sometimes a third of the population, of the child population in the county, is enrolled in Medi-Cal managed care. In some counties, 81% of the child population is enrolled in managed care. And you can see the differences by age based on the graphs on the screen. And basically what this tells me is that Medi-Cal managed care plans are a critical partner in advancing your various priorities related to oral health. And I do think that there's a role that they can play in COHA implementation and reporting. Next slide. So what are managed care plans required to do with regard to oral health? These are outlined in AB 2207, but and in Medi-Cal managed care plan contracts, which is that they are to provide a dental screening for every member that is newly enrolled in their health plan. They also are supposed to conduct oral health assessments and screenings during every visit that anytime that a child or a youth beneficiary visits their provider. And so really they are meant to be monitors of oral health for children and youth, and often have more frequent access to children and youth because of well-child visits according to AAP Bright Future schedules. They are supposed to ensure that if a member is in need of dental care, that they are referred to an appropriate provider. Referred today, there's no data for us to know what that means. Is it that they just received a list of providers, or that they were told to call the Medi-Cal dental hotline or their dental managed care provider? Right now, we don't have great data of what this looks like. They are also required to have liaisons that are available to coordinate care to dental managed care or dental fee-for-service, and to assist with ensuring that individuals receive the care that they're entitled to. Next slide. This is the first sort of data that we, and Dr. Kumar mentioned this in his presentation, on the managed care plan side. This is the only measure related to dental care that we're aware of, or currently. More may be forthcoming through other initiatives that I'll talk a little bit more about later. But currently, when dental managed care plans are thinking about the importance of oral health, this is what they're being measured against: dental fluoride varnish application in the medical setting. And as you can see, this is the latest data. This was released last March for 2022 data. And like Dr. Kumar said, typically this report is released, the preventive services report where you can find this data, is released in Q1 of the year. So hopefully in the next few months, we'll see the latest data. Our understanding is that the state is also working on more interactive dashboards to capture different measures. But as you can see, anywhere between 5% or close to 30% of children receive dental fluoride varnish application in the medical setting. And within this report, the state does note that they count dental and medical codes. So they say that there's caution to be taken when interpreting these results, because the actual percentage of children who receive dental fluoride varnish application just in the medical setting might actually be lower than some of these rates. So that's something to consider. Next slide. So that's on the managed care side. I did want to take a moment to highlight the Medi-Cal dental. So managed care screens and refers, but actual dental care utilization is through the fee-for-service system, the Medi-Cal dental program, fee-for-service system, or through dental managed care plans. And as you can see, there's a better rebound, but this was the only data chart that I could find on the state's website that had 2019 up to 2023. So as you can see, we took a dip during the COVID pandemic, but the state has been rebounding. But at best, about 50% of kids across the state are accessing dental care in a year while they're covered. So there's tremendous opportunity to ensure that children are getting to dental care. We're just at 0.5%. We'd love to see 100%. And we see that there's an opportunity on the medical side to perhaps increase the engagement of primary care providers and any other staff that may be involved in the care of that child when they're in the clinic or in the FQHC for a well child visit or any other routine care. Next slide. And the reason I share the two sort of slides you just saw is because the state does monitor quality and access, but this is the framework with which they assess that quality of oral health delivery or oral health care service delivery. On the Medi-Cal managed care side, it's the dental fluoride varnish application measure. And on the dental side, it's the use of preventive services, sealants, examinations. There are a number of different measures. One thing I would note is that in our conversations with the state, they've indicated that Medi-Cal managed care plans can access some of the data that's collected and reported on the dental side, such as the number of children who are enrolled but have not been to a dentist in the past year, which presents an opportunity, we think, for working with managed care plans to potentially target resources in certain regions, certain areas, because they have access to that data and can hopefully share that with local health jurisdictions and other partners, which we'll talk a little bit about later, to strategize on how to best close this gap and ensure that kids are getting preventive care as needed. Next slide. So now I'll switch to the key opportunities to advance oral health. There are 4 that we see. One is the new population health management requirements on managed care plans, memorandums of understanding that they have to be execute with different entities, and closed loop referrals that they are going to be held to as well under new contracts. There are also new Medi-Cal benefits like the community health worker benefit, but I will not be talking about that because that will be the focus of the project directors meeting in a week. So stay tuned for more on that front. So looking at population health management, next slide. As part of the California Advancing and Innovating Medi-Cal Initiative, the Department of Healthcare Services is requiring all managed care plans to fulfill their population needs assessment requirement by participating in local health jurisdictions, community health assessment, and community health improvement plan processes. So the idea is that they will meaningfully engage in your local efforts, your LHJ's local efforts to develop these plans. And meaningful engagement definitely means participation in the formation of those plans, in the assessment and the collection of data, but it can also mean resourcing, whether that's consultants, facilitation, outreach, whatever may be needed to ensure a robust assessment at the local level. And next slide. In December, which is linked in the slide, the Department of Public Health did issue guidance to local health jurisdictions outlining how managed care plans and local health jurisdictions will align efforts to complete the CHA and CHIP process. So they've outlined that there will be a ramp-up time between now and 2027 to allow managed care plans, local health jurisdictions to build the relationships, articulate the terms of their partnership, with the idea that by 2028, there will be alignment between managed care plans and local health jurisdictions in the CHA and CHIP process. And you can access the guidance that's been issued by the state. It's all publicly available. So it might be that your agency leadership is already reviewing this. Perhaps you've already seen communications about it. or we hope you will soon, because this process has already started. It started last year. Next slide. In addition to, and that's on the left side for me, so for you all on your screens, on the left side is the guidance that was issued by the Department of Public Health to all local health jurisdictions to alert them of this partnership and this alignment that's being engaged in at the state level and how that would impact your local processes. They also have made available a worksheet for managed care plans to articulate how they plan to work with their local health jurisdiction. What type of support will they provide? What data will be exchanged? How will referrals and coordination of information processes be established? And so managed care plans, local health jurisdictions are in the thick of this right now. So as you all think about your local oral health program, your COHIP, I would advise that you look at both of these documents to get a sense of, given all your priorities, COA being one of them, how might you leverage this opportunity and the resourcing that will be available through managed care plans to advance oral health and ensure that oral health is prominent within the CHA and the CHIP. One thing I would advise you all to do is to make sure you check with your leadership at your agency. Next slide. This is just an example. I pulled this from Ventura County Public Health because they had a really easily accessible organizational chart. But you can see the yellow arrow is where the local oral health program is situated within the broader infrastructure of that public health agency. There's WIC, there's tobacco cessation. So there are a lot of priorities that the public health agency may have that they might be prioritizing for partnership with managed care plans. So it's critical that folks engage with their agency leadership to understand where are folks in the conversation with managed care plans, what are some of the priorities agency-wide, how might oral health be elevated within the partnership with managed care plans, or how can a focus on oral health be built and strengthened over time if it's not something that is immediately prioritized for partnership with managed care plans. Next slide, and thank you, Ventura County, for making that so accessible. Within the document that was issued to local health jurisdictions, and I think I got my links split up on this at the bottom for the sourcing. The State Department of Public Health does highlight, these are some of the considerations that you might start to talk with your team about, with your community partners about, in terms of how you might engage with plans and leverage the resources they have to support your COHIP and CHIP CHA processes. Next slide. I think I mentioned them. So like staffing, data. So that's population health management as it relates to the CHIPs and the CHA. Another opportunity as we see it is memorandums of understanding. So the state is also requiring managed care plans to establish MOUs with various entities. And the goal of these MOUs is to clarify responsibilities and coordinate population health, to clarify the roles of each party and how they will support care coordination and connection to different services. It's meant to promote transparency about, what each party is doing and how they are working together for the benefit of the consumer, so children and youth at the local level, and to promote overall accountability and oversight. Next slide. So on this slide, we're highlighting the different MOUs and when they, I don't see the agencies. Oh no, I don't know why they're not showing up. Oh, the graph should have the different types of agencies that managed care plans are required to partner with. And at the true north, blue circle is local health jurisdictions. So those should be effective this year. The state recognizing that this is a labor of love, pain, whatever it may be at the local level. There is sort of a ramp up time in that they are allowing managed care plans who don't have an MOU in place currently, that they show evidence of them in good faith working towards the establishment of that MOU. Other MOUs will be required. Yay, there they are. Other MOUs will be required beginning next year. And the two that I'd like to highlight, given the conversation that you'll be engaging in a few minutes around COHA, is this requirement that plans work with local health agencies and that they work with local educational agencies and even groups like First Five, social services, child welfare departments. We feel this is a prime opportunity to think about how you can close any gaps in information, coordination of services, data exchange between all these entities, given that managed care plans will be sort of the center, holding the center with all these different agencies and partners. So just something to think about as you articulate the MOUs or add on to, there's a base template that all plans have been provided, but that's a baseline. Folks can build on what is articulated in the MOUs that have been shared by the department. Next slide. Okay, so the third opportunity, closed loop referrals. Hidden within the Population Health Management Guide, which is almost 200 pages, is a provision which requires Medi-Cal managed care plans starting January 1 of next year to establish a closed loop referral process for their members. The idea being that if a need is identified during that well child visit for oral health services and follow-up, that the plan, the provider under them, are responsible for coordinating and referring the members to available community resources and following up to ensure that the services were rendered. So as I started at the beginning of the presentation, there's currently a requirement for referrals. I think over time, our organization has requested information on how is that being tracked? How do you know that children are actually, that service is actually provided, when we see on the dental side that only half of children are utilizing their services? So this requirement will hopefully fill that gap, because managed care plans will be required to close that loop to their dental provider. So I think before we hopped on this call, the presenters were talking and someone mentioned that one of the biggest challenges is getting the COHA form back to schools. Thinking of the context of the MOUs, the partnership that will be required with LEAs, between the managed care plan, local health jurisdictions, is there an opportunity to help ensure that information about COHA is submitted in some way, and whatever process works for the local, for you all, you know best what might work best in your context. How can these different levers help advance that goal of meeting COHA compliance? Next slide. So we've went into a deep dive on the closed loop referral policy last year, and we met with various stakeholders. We issued a brief with our recommendations and thoughts on how to promote effective closed loop referrals, putting children at the center of that policy. But as you can see on the screen, these are all the loops that must be closed by the managed care plan as part of their ongoing care coordination for members. And within that, you see that there are dental providers there must be a closed loop for that provider. You also see that there maybe are other programs or agencies where perhaps you have a partnership that you could leverage this closed loop referral to ensure that oral health is prominent within that setting as well. Next slide. So I defer to all of you. You have all the expertise of your local context, the partnerships you have, which schools you're working with. But as we were thinking of how these levers might be utilized to advance COHA, advance oral health, these are by our initial ideas. They are not comprehensive. I'm sure you have better visioning that I can come up with, because you know your context best. One thought is you could partner with managed care plans to educate families and give out the COHA form during well child visits. Do that education ongoing as part of every well child visit leading up to the age 4 or 5. You could request data for managed care plans on the closing of those loops. How many children did get to dental care? Or could you identify sort of opportunity zones or opportunity areas where It aligns with the schools you're prioritizing for COA compliance, looking at which providers are in the local area, trying to see if you can leverage the managed care relationships with their providers to increase rates of return of the form or just increase education. You can also perhaps start engaging, knowing that the requirement of the MOUs with LEAs is coming, will be in place, is required to be in place in January of next year. Could you engage in conversations with the school administrators that you're working with currently and managed care plans to promote alignment, the sharing of data, clarification of roles, and care coordination? Just some ideas. I totally defer to the folks on this call to explore this further. And we'd also love to hear what you're seeing and what you're hearing, because we think it's an opportunity, but we'd love to know more what's needed in terms of support, barriers you're still facing, and sort of implementing this. Next slide. And I think the next slide is my last slide. So you can follow us on any of our socials. We have a blog that we update regularly. And I'm just happy to have shared this information and hope it sparks some ideas for collaboration at the local level. And I'll hand it back over to the SAC team to let me know which, I see the chat has been blowing up, but I have not paid attention to it.
You're covered. Eileen has got your back with that. So thank you so much for the wonderful presentation. And it did elicit so many great questions and dialogue in the chat, and the resources are flying. You can see why we built in a break right now to give everyone a minute to digest what we just heard, catch up on the chat. But before we jump to the break, I just wanted to see let me stop sharing. See, was there any like out loud question that somebody needs to have answered right now that didn't get covered in the chat? Okay, great. So please, we'll take about 7 minutes. We'll reconvene at 10:50. Thank you so much, Fatima and Eileen, for the great presentation and the great resources in the chat. As a reminder, we'll send out the slides, hoping that there will be some sort of summary as well about the resources that were linked in the chat so that you all have access to that. And we'll see you in 7 minutes. Thanks. Okay, we'll get started here. A few seconds, and thank you all for the great correspondence in the chat about and lifting up questions about collaboration with managed care plans. I know it's a lot happening at once for everyone, and how to prioritize oral health is a topic that has come up a few times. So we can certainly continue that discussion later in the meeting and also follow up with resources. And right now, I would like to transition to the next section of our agenda, which is hearing about best practices. So we're really thrilled to have Monica Nicholas. She's the Senior Health Educator and Project Director for Santa Cruz's local oral health program, and Dr. Seppi, who is the Executive Vice President of Operations with Dientes Community Dental Care. And they'll be talking about best practices for building relationships and COA awareness. Welcome. Thank you.
Hi everyone, can you see my slides?
They look great.
All right. I am so happy to be here today. My name is Monica, the local oral health program project director for Santa Cruz County, and I'm really grateful to be presenting alongside Dr. Seppi, one of our strongest community partners in this work. And she's going to start by providing an overview of our coalition and the collaborative work that we've done locally, and then we'll get into best practice and strategies. So I'll pass it over to you, Seppi.
Thank you so much, Monica. Hi, everyone. Thank you for having us. It's an honor to be here with Monica, who has been an amazing partner at the local oral health program. And we've done a lot together, and I'm so excited to be here and tell you about it. So Dientes founded the Oral Health Access Steering Committee, or OHA, which is our local coalition, back in 2015, when we had our first ever oral health needs assessment in our county. When we got that report back, Dientes realized that the need for dental care access is so tremendous that we could not address it alone. So we put together a local coalition of stakeholders to come together, form a strategic plan, and take action. The good news is that in 2017, the state funded the local oral health programs, and all of a sudden we had funding and we had extra support from the LOHP. Since 2015, we've made a lot of progress, as I'm going to tell you in just a moment. And in 2022, we updated our needs assessment, we did a new one, and we formed another plan. So the OHA that Dientes put together is a coalition of health clinics, social service providers, government agencies, education partners, all focused on improving the oral health of our community members. The premise that OHA was founded on is that you do not have to be a dentist to make an impact on the oral health of your community. And as you can see here, we have had a lot of non-dental partners. And connecting this to Fatima's presentation earlier, I wanted to mention that the Central Coast Alliance for Health, which is our Medi-Cal managed care program in our area, has been a member from day one on OHA. And we have worked with them in many ways since the inception of OHA, and I'm going to tell you about that in just a moment. So before I get into telling you how we were successful in building relationships, I wanted to share some data so you can see why we're qualified to even talk about this. So the initial plan that OHA came up with included 4 main focus areas: first tooth, first birthday visits, COA screenings, increasing capacity. This one also included not only dental capacity, but also having medical providers apply fluoride varnish. And then lastly, prenatal or oral health care. So I want to go over just a few data points so you can see how our partnership was successful. For example, for first tooth, first birthday, we went from 37% utilization for ages 1 to 2 on Medi-Cal to 57% in 2019. We had a little bit of a drop with COVID, but as you can see, that's a tremendous change. How did we make this happen? We engaged all of the OHA members to do a community-wide campaign, including the Alliance, to include this information into their newsletters to their members and also to their providers. We worked with pediatricians, told them the importance of first tooth, first birthday visits. We also leveraged our first five partnership in our county to help promote it. And then the 2 dental clinics in our area, we prioritized these children, and we made sure if somebody was calling to get in their newborn, that we would get them in. Again, we engaged our OHA members, such as the Alliance, to promote prenatal dental visits, and we also worked directly with prenatal medical providers. As you can see here, in 2015, only 38% of patients on Medi-Cal who were pregnant were getting a dental visit. And by 2018, it went all the way up to 53%, whereas for private insurance, it actually dropped. Again, we had a little bit of a drop with COVID, but we all had that in our counties. So how are we so successful in building relationships? How did we get people that are not dental people care about oral health? So I'm going to give you some examples. First of all, we contacted potential partners directly. We told them about the need. We told them to be involved, and we reached out to high-level people in each organization because we needed partners who could actually make things happen. We use data to explain why oral health matters for the population that each organization serves. For example, schools really care about attendance. So we talked to them about the fact that dental issues are one of the main reasons why kids miss class. We were super specific about what we were asking the partners to do. For example, for First 5, we told them that we needed their help in running an ongoing First to First Birthday campaign. Or for the Alliance, we engaged them in training the providers and educating their members on fluoride varnish applications in the medical setting, and also for dental checkups for prenatal patients, and also for First to First Birthday visits. Something that was really important is that we embedded oral health into existing workflows. For example, for First 5, they were already doing a kit for every newborn in the county, like a welcome kit. So we just asked them to include a First to First Birthday flyer. We made it as easy as possible for them. So that flyer that I just talked about, we made it. We worked with our local oral health program to make the flyer, and we gave them to First 5. Or when we talk about the pregnancy goal, we told all the OBGYNs in our community that if they had a patient on Denti-Cal or Medi-Cal, that we would take them if they referred to us. Every time we added a new partner, we had an orientation. For example, in 2023, we added improving access for seniors as a goal. So we had all of a sudden a lot of new members. So we had a meeting with each one. We did an orientation. We reviewed the history of OHA and the LOHP, and we told them how they could fit in.
All right, so how does the local oral health program fit into all of this? Stepping into my role as a project director, I wanted to build upon the great relationships and work that came before me, as Dr. Seppi mentioned, while also reestablishing our identity as a local oral health program in my county. Because LOHPs largely operate out of the public health departments across the state, I was interested in how I could leverage that authority to strengthen coordination and collaboration between partners. In this case, schools, dental providers, and our County Office of Education, while providing more oversight of partners, at least initially. Through this process, I'm able to better support the development of more efficient services and systems with uniform tracking and monitoring tools for COA and school-based dental programming. And I encourage you all to establish your LOHP identity if you haven't already. Before I could strengthen LOHP identity in my county, I had to quickly become a mini COA expert in order to be effective in this area of our work plan, starting with number 1, knowing the law, the roles and responsibilities, and the associated funding for COA. I had to re-educate our partners that this mandate is still in effect and that schools are still receiving funding and responsible for distributing the forms to parents, collecting the forms, and submitting the data. This brings me to number 2, being in alignment with your COE and what their preference is for COA workflows. For example, our COE chose to have schools individually report COA data directly to SCORE. When I came on board, we only had 4 out of 10 districts reporting data. In order to build school capacity, our COE support was needed to message this workflow to schools and help to organize district nurses to help manage it. And then my role would be to assist with trainings, technical assistance, and reminders to support COE and schools in meeting their obligations under the COA law. Through this process, I have been able to, through this process, our COE appointed an oral health champion to support the efforts locally once we establish the roles and workflows. And this brings me to number 3, knowing the basics of how the SCORE system works. I found it to be so valuable to be a point of contact and resource for school nurses and staff in order to see an actual increase in the data reporting. This humanized the database, and it's not a perfect system, but SCORE does have an abundance of resources that make learning the basics easy that I encourage you all to tap into. And I'm really happy to see that Gary from the SCORE team is on the call today to provide more guidance about that. But you should know about the user's manual, trainings and videos on their website, and tapping into the help desk, which is very responsive and can even set up individual meetings with your teams. Also, I encourage you to be familiar with the list of SCORE users, which tells you who has established a user login for SCORE by school site and is thus responsible for uploading their data into the system. I share this list about twice a year in fall and spring with school staff for accountability and also to remind them to reappoint someone as staffing changes. And then 4, of course, we need to be tracking the data in SCORE and share that data out with key stakeholders. And I'll come back to tracking in a moment with examples of what worked best for us. These are just some examples of how sharing COA messaging with key stakeholders such as school staff can be done. The one on the left communicates the role of the LOHP and the support we offer. The one on the right messages the role of school staff for COA, making sure to message it as a mandate, why it's important, and some key steps to the process with deadline reminders. So how did we get everyone on board? In our county, we're fortunate that our coalition is already invested in COA, but to keep the momentum going, I developed a sub-work group that myself as the LOHP coordinates to convene with our COE champion and our 2 school-based dental providers to enhance the coordination of COA and school-based dental programming. Together, we established clear goals, objectives, and activities that fit into 3 main priority areas for the 23-24 school year. We were interested in increasing data collection, reporting, and tracking of COA data from school sites to the SCORE system, of course, but also increasing data from dental providers about school-based dental programs and services to the LOHP and to all partners. We also wanted to increase the number of students served. And 3 focuses on using the data reported to the LOHP in step 1 to increase the coordination of our existing school-based dental care amongst the 2 providers. And Seppi will share an example of how this level of coordination helped to enhance our work together.
Yes, so there are 2 dental FQHCs in our area, Salud para la Gente and Dientes, and we both provide school-based services in our community. Prior to Monica setting up these meetings and getting all of us to talk, we were providing services at the schools that were siloed and sometimes duplication. So for example, we were going to the same sites, but we weren't serving what we were really needed. So because of Monica's help and coordination and the meetings, now we're communicating monthly and we're working with each other to fill the gaps.
All right, so this is a snapshot of the tracker that we co-developed to track COA and our school-based dental programming across the county, all in one place, which is transparent to all partners. And if you'd like to see the full tracker, you'll receive the slide deck, and an example is linked here of the tracker that we're using. So as you can see, we have listed out all the schools and districts in our county and also indicated which sites have a school-based program, which are the schools in bold. We also included whether or not they reported COA data the previous year on the far left-hand side. And we've included the free and reduced meal eligibility program rate to ensure that we're serving the highest need schools and to prioritize expansion of services to other sites. So by doing so, this tracker illuminated some successes, like that we're doing a great job of serving the highest need schools in the county. But it also showed some gaps. For example, a Messi Elementary, the second column here, or row, is in our priority district. It's the largest in our priority district, which is the largest in the county with the highest free and reduced meal rates. This school site in particular is at a 93%, And even though providers are increasing dental access for students at this school with the school-based dental program, the school is not uploading any COA data, as you can see. So through these discussions, we also learned that both dental providers were not completing the COA forms on site, which was a missed opportunity. So now providers complete the forms and submit them directly to the school. And this required us to build the capacity of the providers and the schools to complete the forms and accept the forms and so on.
So Monica attends a lot of school nurses meetings and she's very engaged in her partnership. And she asked me to attend one of the meetings with her and I went. And during these meetings, we want to make sure that we're not just sounding like we're telling them what to do, but that we're also offering support about the things that they care about. For example, in one of our meetings with the school nurses, they mentioned that they really don't know what to do when a student comes to them who's in a lot of pain or who has an urgent dental issue. So we created this special referral for them. So now the school nurses, if they have any student in pain, they can directly refer to Dientes and we get that child in within a day or two.
So this is an example of the COA timeline that I use. Every summer, I review the SCORE data, update our tracker that I just showed you, and use this information to prioritize outreach, COA support, and expansion of our school-based services. In the fall, I leverage my COE to provide annual trainings that Seppi was mentioning to district nurses. This is me showing up in person with the most recent COA data, and together we make a plan on how we can increase reporting. I now have standard meeting times on their agenda each month, so I'm consistently building relationships and answering questions and keeping oral health in the forefront. As we continue in the school year, I make individual follow-ups with schools to see what support is needed and incentivize by providing oral health resources to staff. Mid-year, I use Children's Dental Health Month as a great opportunity to integrate oral health in the classroom and send out COA reminders to school staff and parents. In the spring, I work with district nurses to monitor SCORE as data comes in, acknowledge those that have entered their data on time, and send out technical assistance reminders for folks that have not submitted their data, just to see what support is needed. And it helps to know that the LOHP is counting on their district to meet their deadline and is also here to help them do it. So after reviewing SCORE in the summer, this is a great opportunity to celebrate, appreciate, and package your success story. So using the strategies that we just shared with you today, this is a result of our collective success around COA and school-based programming for the 21-22 school year to the latest reporting period, 22-23. We saw a 100% increase in the number of school districts reporting COA data into SCORE. This included 6 schools from our priority district who had never reported before. We had no schools from that district reporting. And we are also increasing access for students by serving 6 out of 10 districts with the school-based dental program, including having a contract to screen all migrant students and screen at all Kinder Roundup events. So there are a lot of ways that you can share your success. Our county chose to host a local stakeholder event. To do that, we started by collaborating with local leaders, like our public health officials and local government, and leveraging existing relationships. Our public information officer is one example who knows all the key players to invite. We also included Dr. Kumar and his team from the Office of Oral Health to attend our event. And at the event, we shared data from our needs assessment, our strategy for addressing those needs, our collaborative success so far, as well as our vision for the future. We made sure to provide partner acknowledgements to elevate their work in oral health. We also invited new partners to motivate their interest to join the movement. We, of course, invited the media, which included developing a press release, media advisory, and scheduling partner interviews in advance. Lastly, we provided facility tours of our new dental clinics and showcased our unique medical dental integration model of our FQHC Santa Cruz Community Health and Dientes, which is a shared campus with their clinics, as well as a brand new low-income patient housing complex. So as a result, we received a ton of recognition around oral health efforts and recruited new coalition partners to help us execute our vision for the future. With that, we'd like to thank you for your time, and we recognize that this presentation was very quick, so please feel free to reach out to me directly with any additional questions or comments, and I'm happy to also share resources and examples. Thank you.
So much, Monica and Dr. Seppi. So clear and easy to follow. Really appreciate your presentation. And we'll have time for a Q&A following the 3 presentations. So I would like to introduce Jennifer Fusetta. She's a registered dental hygienist and the project manager for San Benito County's local oral health program. And she's a wealth of knowledge about this topic. So we're so excited to get some information from her. And again, we encourage you to ask questions in the chat as we go. Welcome, Jennifer.
Hi, and thank you so much. That was a wonderful presentation, Santa Cruz. Thank you. You gave a lot of information. By contrast, I'm here in San Benito County. My name is Jennifer, and we are a very small rural county. We have a population of about 60,000, and we have 11 school districts and 18 kindergarten classes total. So we're very, very different.
Jennifer, I wanted to ask, is there a way to show the presenter view for the slides?
Oopsie.
And if it doesn't work, we can launch it.
How's that?
That's
Is that
great.
better?
Perfect.
Okay. So our agenda today, I'm sorry about that. Our agenda today is San Benito County Kindergarten Oral Health Assessments. When I started in 2018, establishing school partnerships, our packet of information I took to everybody, the actual data collection, the forms, school screenings, oral health screenings in the classroom, challenges and lessons learned, and my contact. When I started in 2018, I started looking around and to see what we had already had established. But what I found out was we had one rural school who had recorded 5 students, and people were going around in my county saying that's what our decay rate was. And that's what it looked like here, which was completely wrong. There was no process in place. The principals would say, oh yeah, I know what that is, but actually they didn't. School nurses were not supportive because they said this was not a mandate, so they didn't care. And teachers told me that it was not a good use of time. So I realized I was going to have to create and just start from 1. So I had to establish partnerships here. So I started talking to everybody. I don't work with anybody. I don't have any dentist available except for one retired orthodontist who moved away. Our FQHC does not work with us. So I started a one-man show, and I went to every county and school superintendent. I went to school principals. I went to the school nurses again, teachers, school secretaries, found out that the school secretaries were the ones who were giving out the form to parents and then we're collecting them in. Although none of these were working very well at all because there is nothing to enforce any of this. So along the way, I kept saying, you know, I want to get this done for our county. I was born and raised in this county and it really matters. And I started doing presentations for everybody on why this was so important and how it affected them and children. So on my last school that I couldn't get at all to be in compliance, I started using the word compliance, and that finally worked with them. But along the way of talking and introducing myself to everybody, I actually I found one champion who then has since moved on. Wherever I go, I think this is the tip that I learned that helped me the most for those of you who are having trouble getting your schools to be in compliance. I always brought all of this information with me and I left it there. And what I found out was some people, depending on who they were, would read the law, didn't know about it, educate themselves. But I think the one that really impacted this was not only the law on Senate Bill 379, was the letter from the California Department of Education, which is that Tony Thurman and Dr. Kumar letter. When they saw that, things really worked for them. They clicked and they said, go ahead. Some people didn't care about the law. They told me they didn't care about the law. They thought it's none of anybody's business, the law or anybody else. But when I showed them studies on academic performance and poor oral health, that clicked for some people. I also had why oral health is important and how kids don't learn as well and how they miss school. That clicked. But I have to tell you, the best thing I did in my county was show these pictures. When I showed these pictures, nobody else cared about what else I brought. The only question I got was, is that here in San Benito County? And I said, yeah. So you're part of the solution, but you have to let me go in and you have to help me identify these children so that we can get help. I can't tell you how many people by the pictures alone let me get in, to the point now where I do have 100%. And then of course I always bring a toothbrush kit and show them that this is also what the children will be doing and getting, and we'll go over that as well. So that's what I used. And these packets I bring everywhere I go, and I leave them because at that point they may not want to look at it, but maybe later on when they're convincing somebody else. In fact, I know that now somebody, not me, took this to the board directors of the school board, and they looked at it, and now they 100% want me to do the entire school, which of course I can't do by myself. But I want to talk to you also about the data collection person. I did have some problems with this. You do need to be a licensed dentist or dental hygienist of any capacity, because on the form, and we use the July 2022 forms, you have to have the name of the dentist or hygienist, you have to have your license number, and if you're going to be a dental assistant working with a dentist or a dental hygienist, that's fine too, as long as everybody is being consistent with the Association of State and Territorial Dental Directors so that it can be more consistent. Although in my county, it's a little bit different because I'm the person who is consistent. What I've found out with these forms is the healthcare, either the secretaries or the health clerks were giving this out and nobody was collecting them. So my thought was, wow, I've got 800 kids that I've got to get to a coordinator or provider. It would sure be a lot easier if I could go to the kids because I'm one person, and since I'm a hygienist, I could do this. And then when I started looking at the forms, although they weren't being collected, but the ones that were, they were being improperly filled out. They were getting filled out by parents. There was a school secretary who was also doing them. And when I would check, they were completely wrong. I even had dentists who were doing them. And when I would double check them, they were not getting done right. And I think that this is a problem that we have not looked at. And nobody understood the importance of this, because when I tried to explain to them, the parent cannot do this. The parent didn't go to dental school, or the school secretary who was arguing with me. And that day I did happen to have a friend of mine who is visiting me, who is a dentist. And he flipped out his phone and he said, "Do you know what this is?" And she said, "No." And he goes, "That's decay." So they are not qualified. And we really do need dental people to do this part of it. So what I did by myself was I figured out, okay, I'm going to have to do the forms. Forget about sending these forms to everybody, because I was never, ever, just getting all the forms back for all the kids was going to take me, it was probably impossible to do. So what I do is I call, sometimes I do a month now, or a week before, depending, because everybody knows me now. I collect all the information I need. I collect the teacher's name, where they are. I get a classroom roster, number of children. I arrange and tell them, please alert everybody with this passive consent, I'm coming this week. Sometimes I'll call the nurses and say, you know, when are you doing your vision and your hearing screening? Can you add oral health too? We're going to be coming this month. We're going to be doing all the mandates. And I tell them, all I need is a small area. Please let me know. The day before I go to the classroom, I've got that class roster. I fill out everything, and I bring, as you can see on the slide, I bring flashlights, a toothbrush kit, I bring a provider list, I bring a dental screening result form, so I can give that result form. I staple it together, I give it to the teacher, she puts it in the child's backpack, and then later when I do care coordination, I follow up with that. But I bring all that stuff, cavity wipes, everything I'm going to be needing, and the day that I'm there, I walk into the classroom, the teacher knows I'm going to be there. I do a quick demonstration for the children so they are not afraid. I give them their prizes as a toothbrush kit, a coloring sheet. Occasionally, I will get a child who is afraid, and it's very simple. In the classroom, it seems to be a lot less threatening to a child than being at a dental office. I have that child come and sit with me. I give them a little job. And by the time they watch everybody get done, I have never had a child not want to do it at the end of the class. So you can see me there. I'm in the back of a classroom doing the actual data collection there. And here I am again in another classroom, and I'm taking pictures and I'm doing the assessment. I brought a health assistant with me. She's writing down the data as I'm reporting it to her. Sometimes the teachers, be right out of the room. It takes less than a minute. I'll call them out. They'll go right back. I've already got the form, and that's what I'm using. First thing I ask is, anybody absent today? I go back and get those. Challenges and lessons learned. This might be for everybody out there. Not all schools are the same. Some schools did go with this right away, and you really have to work with them. Not all teachers are the same. I still have teachers who don't agree with oral health. They think it's nobody's business. And that's just the way it's going to be. You're going to have some of those teachers who are not supportive, and there's always going to be somebody who's not supportive. For the most part, though, we do. School nurses don't always think oral health is a priority. I know here in my county, they think diabetes is. Things I learned that really helped me. Make copies of the form. I always make copies of the form, because that way when I'm doing follow-up, I've got the form. I can speak to that child. They've got their form. I've got my form. I can make my data with it. I always take one person with me. It's really good and helpful. Sometimes they even know the kids, or sometimes if something goes haywire, they're there to support. Be flexible. A couple times I've had teachers say, "Oh, go ahead and do it right in the back of the class. Just be quiet." We do it. Sometimes they say, "Just pull them out in the hallway. We'll do it there." Sometimes they'll say, "Go to the gym." One of my last schools that was the hardest to get into, they used to bring the kids to me in a gym. Now they know me. I can do it right in the back of the classroom. It's very, very easy. I'm really quiet. I always tell them, "Thank you so much. Thank you so much." And I show them, because when I first started, I used to say, "Oh, do you ever have any problems with oral health in your classroom?" Every single teacher said, "Oh, no, of course not." But they're not looking. So when I would find, for example, this child that I'm showing you, I would call them over and I'd say, "Did you ever notice this?" And their eyes would get really wide and they'd say, "No, I have no idea." And I say, "That's right. You don't have any idea, because you're not looking in their mouth. You're not a hygienist. But thank you. Thank you for letting me do this, because now you have helped me identify this child. I can get the parents' names and we can get them help." And so they really like that. And I tell them it really, really does matter. So that was super quick. I could go into a lot more detail, but I know I don't have time. There's my contact list. I'm always happy to have you call, ask questions, and I really appreciate you letting me present.
Fantastic. Thank you, Jennifer.
Thank you.
And very helpful information. We have just a quick question in the chat, and you can respond in the chat if you'd like, but I'll just let you know. Was there an MOU in place for all the districts you went into?
No, there wasn't. And I would say that, and they would say, "Well, it's a mandate, so you're covered."
All right.
Some do, some don't.
Thank you. And so, yeah, and so if you have the capacity to respond, there's a few more questions coming in on the chat. And then I'd also like to turn it over to our next presenter, Gary Flores. He is a coordinator for CodeStack with the System for California Oral Health Reporting, known as SCORE. And Gary will be talking about top 3 SCORE questions. Welcome, Gary.
Thank you very much. It's great to be here. It's great to see everybody. Well, almost everybody. So a couple of the things that we wanted to discuss, and we can kind of go over them rather quickly. The top 3 things that are, again, like Lindsay had mentioned, the top 3 questions that are coming in through the SCORE help desk. And then I also wanted to kind of give you guys a little update as to, what's coming, what to expect, and those types of things. So the first big question that we get is, are Spanish forms available? Spanish forms are not yet available through the SCORE system and through the CDE. CDE is still working on that, but we have been given permission. San Mateo has created some Spanish forms, and I'm actually going to put that in the chat so you guys can all have access to that. They were gracious enough to kind of allow us to share that out. So San Mateo does have those forms available. The other big question that comes in, when is the deadline to submit? CDE says that most the oral health assessments need to be reported by May 31st of the school years, and the county offices have until July 31st of the school year. We do, so then the follow-up question is can we continue to submit data from the previous year? So the number 3 question is that, and the system does still allow you to report the previous year's data. So if you do kind of miss those deadlines, there is still the ability to add that to the previous year. So if you're still a little bit behind on last year's reporting, you can still enter that data within the SCORE system. Those are the top 3 questions that come in through the SCORE help desk. Obviously, there are some things that come in that are things that we do not or cannot answer, and we send those over to Paula and her team at CDPH, and they do a wonderful job of taking those questions on from there. A couple of the things that I wanted to share with everybody is some of the questions that we get are some of the other additional questions we receive are the training video. We are currently in the process of getting ready to recreate the training video. There were some things that, as we were going through it, that Paula's team and we felt that we needed to update. So we are going to be sending that script over to Paula today so they can kind of vet it to make sure that everything is okay. And then once they give us a thumbs up, then we'll start scheduling some time within our department. The nice part about working here at CodeStack is we have a media department that helps us actually produce the videos here in-house. The second question that we get quite often is training. We were doing some monthly trainings, and we stepped back and we kind of started to kind of reevaluate that, and it was actually it actually works out better if you would like technical training on the SCORE system. We ask that you reach out to the help desk, and we'll kind of customize the trainings directly for your agency, your district and county office, because we do understand that everyone uses SCORE differently. So we really want to make sure that we can customize that training for you and your agency, your district or county office. So if you are in need of any of the training, any additional training on SCORE, please feel free to email the help desk, and we'll schedule a time. We'll have some follow-up questions for you just so we can make sure that we're addressing all of your needs and concerns there. The other exciting news that we're working on with CDPH is updating the SCORE homepage. And in doing so, we are going to be adding a lot more information that will be useful to you as users of SCORE. We're going to provide you with a lot of different links that will hopefully help answer some of the questions that you may be running into that may or may not be SCORE related. There will be some times that, and some of you who have emailed the help desk, we do sometimes have to refer you over to CDPH, but Paula and her team and Rosanna have done a great job of editing some of the homepage, and we're trying to just get the final touches on that so we can provide you with more information there on that homepage that will be useful to you when you're looking to report data into SCORE. Those are the main updates that we have, and some of the 3 top questions that we get within SCORE. So if Lindsay, I don't know if you wanted to open it up to any other questions.
Sorry, a quick question is, do you know when the homepage is going live? That just came in on the chat.
So once we receive the final edits and we get that back to Paula and her team, and it should go rather quickly, the updates, because it's not a whole lot. So it's not a whole lot of work that's going into the actual update. We're doing a lot of text updates. So we're hoping to get that out by the end of February. So you'll see some major changes to that homepage there.
Great, thanks. And then there's a question, can we take down the score video on the site since we already know there are flaws in entering data? Training video.
So Jerome, that would be a question that I would definitely want to talk to the CDPH and CDE team before the SCORE team just makes a decision to take that off. So we do have monthly meetings and check-ins that we talk, and we can definitely put that on the agenda as to a possibility until we update that. So hopefully that answers your question there.
Go ahead, Jerome.
Hi, everyone. Thanks for letting me speak real quick. I just wanted to bring this up because I think it's really important, because I know we've talked to Gary before, and as far as the training video, I know Keyher is no longer in there, but a lot of the nurses that I've talked to, as we talked to them, they were kind of confused because as you go through the training video, it tells you that the state requires you to enter the first 9.
Correct.
And the 2 through 9 should equal 1, which is the eligible students. And the training video tells you the bottom, the rest below 9 is an option and it's not required. On number 11, which is below 9, it's untreated decay, which is one of the most important data points we need.
Mm-hmm.
Number 12 is Carrie's experience, which is an important data we need. And total number of students who have no obvious problems found is an important data we need. So if we can take that out, that would be great, just because it's confusing the nurses right now, because any delay would just mess up the data.
No, absolutely, Jerome, and we do understand and appreciate that feedback. And again, like I said, I would before we remove it, I would like to talk to the CDPH team and CDE team just to kind of get the consensus. If they're okay with us removing that for now until the new one is up, then we would have no problem taking that down for now. So
Great. Any comments from?
And Jerome, those in the new training video, all of that will be addressed and clarified. So in the updated video, it'll be clear. And so just want to give you that peace of mind that is being addressed in the next video.
No, that's great. I appreciate looking into that, Gary. Also, since I have everyone in here, I just want to bring up a really important point that I keep running into with the nurses. Is there any possible way, I know this came up in the last meeting, is there any possible way that we can collaborate with the software that the schools are using with SCORE and aside some funding for that? Because their number one goal, I don't care, they don't care how many, I know San Diego made an amazing dashboard, San Mateo made an amazing dashboard, we have an amazing dashboard. Talking to the nurses, they don't really care about these dashboards, how color-coded they are, how easy it is. It's the amount of time they're double inputting this data. So if we can come up, when I talk to the ARIES portal, which is the majority of Orange County districts, it's an ARIES portal system. And there's a way where you can actually put the 20 data points plus the CDS code, and they can do a query search, do a CDS, do a CSV file, and do it really quick where they can just send it out to SCORE, where you guys have the quick input. If we can concentrate on that, I think that would solve a lot of problems, because it makes input easier, and there's buy-in from the district nurses. So I think if we concentrate on that, we don't have to waste time with things that the nurses really aren't interested in doing. And I know LOP does such a wonderful job in all the counties, making it easier for all the nurses to upload to SCORE. But if we want the data to be to go fast pace and have a lot of buy-in, I think that's a direction we really need to go.
Thank you. Thank you. Yeah, and I want to open it up too to our other presenters. We're now in the Q&A session, so thank you, Jerome, for kicking it off. Gary or Jennifer, did you want to respond to that? Or Monica, Dr. Seth?
I just think that the nurses are really overwhelmed and they don't want, my nurses here don't want to have any more work. So I actually am the one doing the score, and I send them when I'm done graphs and things of that so that they can very easily read it. And that's it.
And I think there was a question about maybe giving them a faster way to put in the data. So any thoughts or comments on that piece? Go ahead, Gary, if you're going to say something different.
I think it's kind of tricky, only because it's if every district and county office was doing the same thing in how they were collecting their data, it would be easier for us to kind of maybe try to come up with a solution. But because there's not one central way that everyone is collecting and or reporting it, it may make it difficult to come up with just a unified system of this is how everyone should do it. And we certainly on the score side, we have our templates that can be used. And one thing I didn't mention, and I forgot to mention, I apologize, is that the 20, before I just say it, I want to make sure the 2021, the 2006 to 2021 format is still being accepted through the data uploads with the score system. So you can use the old forms and the old way that you were collecting the data and upload that into the score system, as well as the new format is there. So I just wanted to throw that out there. I forgot to mention that. So that would just be my 2 cents in how it might be challenging to come up with a solution for everyone to kind of use the same data collection.
Yeah, I'd be happy if I could get anybody to do it. The nurses won't do it, the schools won't do it. And at our county office of ed, they just looked at me like, there's no way we're going to do this. So that's why it fell on me. And I don't actually mind doing it at all. That's why when I keep my farms, it's a lot easier. And as soon as I get it, I try to do it. So, but that's just my small community.
Thanks for giving an example. So yeah, Ariel, go ahead.
Yeah, thanks. I really appreciate all the information from Gary, Monica, and Jennifer. It's really helpful new to local oral health to hear what's going on. And I just got a notification from Zoom saying I quit unexpectedly, so hopefully you guys can still hear me. What I'm wondering is, I'm hearing a lot of people saying they're doing their own data collection, going into the schools, and I understand the capacity issues, certainly. My understanding is that the spirit of the passage of this law was to get children into dental homes. So the idea being that they would go to see a dentist. And so conducting a screening on site doesn't necessarily align with that goal, although obviously if a child has decay, they can be hopefully will be connected to care. So is our goal as LOHPs to get the best data, meaning we are going out and doing this direct service? Or is our goal more to connect children and families to care, which might mean we don't have as robust data because we're working with smaller groups? So I'm just trying to understand what our goals are as a collective.
Thank you. Dr. Kumar or Rosanna, would you like to respond to that question? And would you like it repeated if you're, or Paula?
I am very happy to answer that question.
Yeah.
Okay. I want you to take a look at San Francisco, what they did. They used the data to drive the interventions. And that's how they were able to bring down caries rate in San Francisco. So we want to replicate that in every county. So in public health, what you measure is what gets done. So if you start measuring, and measuring it accurately, you start seeing the results. So to us, data is very, very important.
And I think I can speak to that a little bit, at least in our county. I think the data is super important. So for us in our first needs assessment, the COA carries rate in our county was 24%. And then by the time we got to our 2022 needs assessment, it was down all the way to 18%. So the goal of COA is, yes, to get access to care and to be referred to a dental home. And a lot of us, like for dentists, we're not doing screenings. When we're filling out these forms, we're doing actual exams, x-rays sometimes, fluoride varnish applications, cleanings, even sealants. So the forms, I feel like they are helpful in getting people into dental homes, and the data speaks for itself.
Yeah, and it's so easy. You do your screening, you get your data, and you just give them the result and get them to the help. But like when I started, our decay rate here in San Benito County was like almost 70%. And now we're under 50. And I didn't think I was going to be able to do that myself. I used to tell people in the beginning, I don't know what I can do. I'm only one person. But I have to tell you, when I'm looking at my decay rates now, we're under 50%, and that's because we weren't ever. Dr. Kumar is so right on. You look at the data, you look at where you are, and then you can see. So thank you.
Congratulations on the progress. I want
Just
to,
as a
go ahead, Paula, and then we'll go to
just
Christina.
to respond a little bit on another side of Ariel's question is, dental, when we go into on-site screenings, a lot of these kids aren't accessing or know about going to a dentist. So doing the screening itself is connecting them. The end goal is the referral process, is connecting them to a dental home. So it's not just about data. Data is a big piece, as everyone has just shared, but it's also really on-site screening is to be able to, that might be their kids' first contact with a dental provider, to be able to even someone looking at their mouths. And then the hope is not only do we assess any urgent care, of course, all the stuff you probably know, Ariel, because we've had discussions, but to then have that closed loop referral to get them connected in a home. So that's it.
Thank you guys so much. And Dr. Kumar, and I'm sorry, Christina, I know you had your hand up, and Andrea maybe have follow-up for this as well, but I'm a newer staff to the LOHP program, about 6 months. And so you're mentioning what San Francisco did. I don't have any frame of reference for what that is. So if there's any sort of written documentation or information on what they did, I would love to see it, just so I have a frame of reference for what you're referring to. And I'm not sure if there are other new folks, but if that could be shared, that would be greatly appreciated.
Thank you. And so we'll start with Christina and then go to Andrea. And then we had a couple questions come in for Gary. So Gary, if you're available to answer those in the chat, let us know. Okay, go ahead, Christina.
Sarah from Sutter County. I actually just have a question for Monica from Santa Cruz. I really enjoy your presentation and congratulations to the county. Quick question. So my partner and I were just wondering, were your school districts, were they passive consent or active consent when you were doing the COA stuff? Because we, certain school districts don't want to be active. So we're just kind of curious.
Yeah, so thanks, Christina, for that question. So as Dr. Seppi was mentioning, our school-based dental programs provide comprehensive care to our students who are doing more than just screenings. So that requires us to have permission from the parents in order to perform those services. So we do need to get permission from parents. Dr. Seppi, did you want to add anything to that?
Yeah, I just wanted to say that we send out the consent forms ahead of time and the health history forms ahead of time, and parents sign up if they don't have a dental provider. The ones that do have a dental provider, the schools are working with them to bring the forms to their dental provider and have them sign it. I know that we also do, I know our partner Salud para la Gente, they also do some screenings during Kinder Roundup, but I'm not sure what the process is for that. I believe the parents are present during the Kinder Roundup.
Andrea, go ahead.
I just had a quick question regarding the follow-up. So when we are actually just starting our process and going into the kindergarten classroom, for the first time to do screening through an RDHAP. And sorry, and I think my question is, who does a follow-up? So our nurses are pretty involved. They're all excited we're coming. And so I told them, so once we go in to do the screenings, they will get the forms. We'll keep a copy for our data collection, and then they would be responsible for the follow-up on those referrals that are made. Because I want to have that loop, you know, I want to make sure that those kids that are an urgent need actually do get the care that they need. And I'm wondering how other counties work that in a way that that's done. So is that responsibility of the nurses, or is this something that we as a county do? I don't.
Well, everyone is silent, so I'll chip in.
Okay, thank you.
Okay, so basically you are implementing a school linked program in a school. So you treat it as a school linked program, and there is a lot of training available. Hopefully we'll have more about how to link children to a source of dental care, either through in the next, I think next session, the chief of the medical dental division will talk about care coordination. Paula, do you want to add anything about school linked program manual and resources available there?
Yeah, we have on COTAC, we have a school linked manual that is available, and we'll put in the link here shortly. And then, you know, a lot of it is, you know, some of the partnerships building that I think a lot of our presenters has talked about in terms of really it's coming together and discussing what needs to be done and who might be able to do it. So I know a lot of it is that partnership building. Thanks, Kristen. She just posted that manual in terms of creating a closed loop referral. But we could definitely, Andrea, feel free to reach out. I'll put my email down and we could, you know, discuss strategies for your specific situation. So
perfect.
Yeah.
Thank you.
Thank you. We also have a couple questions coming in about, there's a question, do schools have the capability to bill for oral health services? They can bill for behavioral health, but why not dental services too? And there was another question about why can't COA be part of the mandated health services for like vision, hearing, and scoliosis screenings?
Oh, that's a lot of questions in that one.
Any thoughts on that?
So there are mechanisms, but it's complex when it comes to dental. That's why schools don't want to get involved. You know, they bill for occupational therapy, you know, physiotherapy, speech therapy, and so many other things. But when it comes to dental, it's a little bit complicated. There are maybe that's something that, you know, we can Paula, we can explore that and provide more guidance about that. What was the second one? It's about why hearing and vision, but not dental, right?
Right.
So that has been an issue when it comes to dental. It's not part of the whole body. You know, usually mouth is treated separate and distinct from rest of the body. And that's what we are trying to address, integration. Part of the reason why, you know, vision and hearing are mandated is because there is direct evidence that it affects learning. When it comes to dental, we have studies showing that it affects performance, but it's only when children are experiencing pain. So that's the difference between dental, vision, and hearing.
Okay. Well, as I know, we covered a lot in our presentations and the discussion's been great. Just thinking about if if it comes to you, if you can share one tip or tool that you learned today in the chat about maximizing COA success, I think that's how we'd like to wrap up this portion of the discussion. I know everyone's in different places. It's been great to hear creative approaches if you're in different sized counties, and ideas for how to elevate oral health as a priority in this work. So if you were inspired by something today, there will also be an evaluation, but it would be great to see in the chat something you'll be taking away tangibly about how to maximize your COA success. And so we're going to move into our wrap up for today. And I wanted to thank our presenters as we move into that. So we had a great overview of Fatima's presentation to start. And then we heard from Monica and Dr. Seppi and Jennifer and Gary about how to maximize our COA success. So thank you all for taking the time to share in a very short time frame what's worked for you and for the robust programs that you've built. So as part of our wrap up, we're circling back to the California Smile Survey. We can go to the next slide. And we did a little teaser at the beginning, but here's some information about what is planned for the California Smile Survey. It's a statewide oral health assessment of third grade students in California public schools. The previous assessment was 5 years ago. It shows the oral health of California's children, and the goal is to help with identifying the need for additional dental programs. 180 schools in 45 counties will be assessed. And then we can go to the next slide. And selected third grade children will receive a free dental screening, and parents and guardians will receive the results. The Office of Oral Health will hold webinars soon to discuss the surveys with LOHPs. And as we think about the California Smile Survey, we do have a poll where we wanted to ask, just get a quick pulse on what incentive you think would persuade kids and schools to participate in the California Smile Survey. So if you can, if there's a poll that's up right now that you can answer. If you think there are other incentives, you can drop them in the chat. But the poll question is, what incentive would persuade kids and schools to participate in the California Smile Survey? The options are class party for the most returned forms, colored wristbands for finishing different steps, extra recess time, a drawing for a gift card for parents, a drawing for a gift card for teachers. So we'll give everyone a minute to answer that. And we'll also, again, there will be webinars to dive more into the details of the survey, but this is very helpful initially to get your thoughts on incentives. All right. So it looks like the winner so far is the class party for the most returned forms, followed by a drawing for a gift card for parents, and then a gift card for teachers. So thanks for taking the time to respond to that poll.
Lindsay, I just want to say, I have one comment.
Yes, please.
So the way the sampling is designed, it's more important to get schools to participate than more children to participate in a school. So you have a lot of say in recruiting schools. So we urge you to recruit every sample schools. So we can't think of any incentive for schools to participate. So if you have ideas, please forward it to us.
Okay, so it sounds like it's two-part, that the first, that is most important to get the schools that were selected.
Right.
And then so okay. So if you have ideas for incentives to get schools as a whole to participate, you can include those in the chat. There is one question: would we have already been contacted if our county or school were participating?
Hi, Lindsay. This is Shannon.
Oh, go ahead.
We haven't contacted any local health programs yet. It's in the works, but we will be reaching out. Thank you.
Thank you, Shannon. Okay, more to come on that. So we can go to the next slide. Thank you. So we hope today's meeting has been a helpful overview of strategies to maximize COA success. We have a fantastic planning team, Henry Torres, Jennifer Pusetta, Aya Ali, and all of our speakers and oral health staff who helped put on today's event and are also planning tie-in with next week's event. Do have to say that Henry had a great idea of calling this Aloha to COA. So that was our alternate title for today. So we just appreciate all of their hard work in putting this together. And we would like you to complete the evaluation for today. We'll drop it in the chat. It has been dropped in the chat and it will also be emailed to you. So we would love to hear from you. We appreciate your feedback. We know it was a lot to digest, we packed a lot into this 2 hours and are so hopeful that you can take away a lot of great tools and resources. And if there's something you still need support with, please contact the team because we want to make this a success for everyone. We look forward to seeing you at our next meeting at 10 a.m. on February 14th, School Dental Programs, Integrating Care Coordinators and Community Health Workers. Rolls right off the tongue. And if you have not registered already, we just dropped a registration link in the chat for next Wednesday's meeting, and we will be continuing the discussion there. So aloha for today. Good luck with your COA efforts, and thank you all for the great engagement in today's session.